welcome to Pediatrics. Most of you are almost at the end of your program. Some of you I know are taking OB with Pediatrics at the same time. If you are one of those people and you get lost in any concepts, please meet with me, because Pediatrics is like med-surg too. It's a lot of really intricate things that you have to put things together. But I will let you know, the way I teach, and then the way that I do the cahoots right after, I'm teaching you how to think if you pay attention. So I don't just give you a cahoots question that will immediately test your knowledge on the concepts you have to know, but I'm explaining why the answer is correct and why the other ones are wrong. So you will be starting that thinking process. It is amazing how the beginning of the term to the end, I see students' brains just all go, "Ooh, I get it, and I understand it. And this happens because of this, and I have to look for that. And that's what I see, and this is what should happen, and I have to do that." All of those things are going to start making sense in the end. So welcome to PEDS. Now, I've been with Fortis since 2017. I started on ground. I was doing the pediatrics and pharmacology. So I am actually your dosage calculation expert. If you have issues with dosage calc and want to learn it quick, I can teach you how to do it in less than a half hour. I will be sending you a recording and 3 worksheets. And if you review that recording, do the worksheets, you still don't understand, make a one-to-one appointment with me. Less than a half an hour, I'll get you thinking. I can even teach you mics per kilo per minute that quick, okay? It is actually easier than you can ever imagine. After teaching it for 5 years on ground, I just learned how to do it. It is not dimensional analysis. I don't understand that. I make those, whatever you're looking for, easy. How do I pull out? What am I looking for? What do I have on hand and what quantity it come in? And I only use 3 formulas. I use mLs per hour, drops per minute, and DHQ, or what do you desire to give over what's available and the quantity comes in. So I make it very, very easy if you need that help. Those 10 points on a quiz, on your exams, can make you or fail you. So I don't want anybody to get any math wrong. So if you're that person who needs help, please just holler to me. I'll make an appointment and I'll work around your time frames. So today, week 1, it's going to go quick. I'm going to tell you not to ever get behind on things. As we go over stuff, I'll tell you what's open and available for you to do ahead and what is not available. Basically, your case studies, I don't have them ahead. Only 1 week before they're due. So the rest of the stuff, hold on to it and just put it in there when those dates come up that you need them. Discussion questions, I have your NCLEX open, and I have your next gen case studies open, that as long as you get them in by the due date. But let me go into that on this PowerPoint. Now, I have a question to ask you. You can do this class 2 ways. Now, most classes will be a PowerPoint, and then I'll follow it with a cahoots. Now, many students decide they want to go straight through, get it done, because I don't mind if you have to go up and go to bathroom. I mean, please go to bathroom. If you have to eat, because I know you're coming between classes, I know that your times is very, precious. And I don't mind you having something to drink while you're with me. But if you want to, we can take a break in between the PowerPoint and the cahoots, or we can go straight through and I can get you out 15 to 20 minutes ahead of time. What do you want to do? Do you want to go through and get out early, or do you want a break in the in-between?
Straight through.
It depends, because my last teacher said that we were going to get out early and we never got breaks, so we didn't ever get out early.
Well, Justin, do I get you out early?
Yeah, you did.
Okay.
Okay, I'm good with that then.
Oh yeah.
Okay. All right. Very good. I usually do. There's 1 week you'll go late, and that's week 5. But that's cardiac respiratory, and it is a bear of a week. Okay, so I want to make sure you get that information because it's so hard to understand. So that's the only week that I do go over, and that's usually maybe 20 after. But usually you are out early. So Samantha, if you find me, I'm running through, please let me know. Hey, we'll take a break now, next week. Just let me know, keep me honest, right? And I don't mind being corrected. I'm not that person that holds, grudges. I'm not that, okay? So just keep me in line and I keep you in line. That's all we do here. So this week, we're gonna do that orientation PowerPoint like you've heard before. I'm gonna go over it briefly, not crazy in depth. You've heard it. I'm gonna tell you those things that are important to me. We're supposed to be all grading all the same way, etc. But I know that everybody's a little different. But I'll tell you my way, which is the way Dr. Brown wants, because I've been working with her a long time. So I know that that's the way it should be done. Then we're going to do our PowerPoint for week 1, and it covers 6 chapters. I did send it ahead of time, and you did see it in your Canvas as a message, I believe, okay? And if we have time, we'll be doing a Kahoots. If not, I will send you that Kahoots, okay? Hold on, somebody's trying to get into my gate. Hello? Hello? All right, person didn't want me. Sorry, my husband's not answering the phone. It means he's busy outside doing something. Okay, let's start out with, like the last class I did, I couldn't do the Kahoots. It was 5 after 5. I stopped. I'm not going to pull you over the time. And I sent it to you. The first week isn't as in depth as the next couple weeks go, because you'll see them 40 and 50 questions on each Kahoots. And I do change them every term just to make sure that concepts that I'm seeing that are missed in HESIs, that I'm making sure it's covered. And those questions missed on the exams, I will make sure that the concepts are covered in the Kahoots to make sure that you're getting all the information that you need to be successful, okay? All right, let's go ahead. Let's start out with the one, and you've seen it already if you've been to community already. If not, you're going to see it next. But it talks about going into what is online and what do we expect from it. Well, online should be treated like you're on ground, which means come to class prepared. I want you to know that attendance does show at 1 minute after 3, you're 15 minutes late, because it's 15-minute increments, just to let you know, okay? I mean, I would say I'd give you 1 or 2 minutes. I mean, what's the big deal? But they have gone in and corrected me. So I'm letting you know it's 1 minute to be late. As long as you go to the end of class, you'll get all of your attendance. And again, I am that person that if you have any issues, problems, concerns, you don't understand, please contact me. Now, I'm also the lead pediatric professor. So if I'm not giving you what you need, please contact Dr. Brown. I don't get offended. You need help. You need something. I want you to do that. Hold on a second. Oh, he's out there tripping over stuff, fixing the bathroom for me, putting shower racks. I don't know what he's doing. Anyway, so if you need to, please contact Dr. Brown. Now, Dr. Brown, I don't mind you contacting her. She'll tell me that you contacted her and you know what the issue was. I'm actually pretty good with answering emails. I have it on my phone. So even if in the evening I'm done, teaching per se, I do check my phone and see if there's any of those last messages, things that you need. Now, let's say it is something that you've got a 2-hour little block of time that you can do your assignments, right? And in that 2-hour block of assignments, you don't understand something, so you can't do something. So now you're like in a panic mode. I got to get this done. This is the time I get it. This is the time where you're going to text me on my cell phone. Now, my cell phone is listed under the welcome, but let me give it to you again. It's 305-951-8055. Now, remember, I am on Eastern time. So if you're going to be contacting me, and well, most of you aren't, you're mostly Eastern time with me, but just be conscientious. After like 8 o'clock at night, most likely I'm not going to answer, or I might, depending if I'm, sometimes I go to sleep early, sometimes I go to sleep late. I don't know. Depends on my days and how early they do start for me. And on weekends, just give me till noon to answer those questions for you. I like to have a nice leisurely breakfast with my husband in the morning, and many times my grandson is here, and that's our time we get together and make pancakes and do all those things that you do with your kids, and it's fun time for me. So wait till noon, and then again you can contact me up to like 8 o'clock at night. So I'm pretty available for you. So again, any problems? Number one, if you have time to send me a message. Send me a message in Canvas or email, whichever way you like. I'm telling you, I'm pretty quick with getting back. Less than 24 hours, sometimes within minutes or within hours. Again, when you're contacting me, please tell me exactly what you need. Always be professional, because you're going to be professionals when you're done. There's registered professional nurse is literally your big title when you are done here. Those using cap things and all that, we know how to do that, and we're not going to be yelling at each other. If I use a caps, it's not telling you I'm yelling. I never yell. That's just not part of me. There is a discussion question due on the first week. Your initial post is due by tonight. Remember, it is APA. I want a reference in there. And then cite in the body of a paragraph, like Perry, 2022 in parentheses, and put it somewhere at the end of a sentence in that paragraph, which shows me if that's where you got your information from to answer those questions, okay? Then you have 2 peer responses. Listen to what you're going to read or listen to the other students, what they have to say, and make a comment about it. Because, we all don't know everything about everything, but sometimes students have a different angle, a different view, and it does open your mind to think a little bit more. The way that the discussion question is said, the instructions, you have to wait to do your peer responses. I don't mind if you do your discussion question and answer them, that's okay with me, okay? Now, discussion questions, you'll see a due date. That is, you'll get your full credit for it. Case studies, NCLEX, any of those that are due, if you do it by that week, that Sunday night, by 11:59 p.m. Pacific time, so it gives us Eastern people another 3 hours, okay? If you can't do it on time, it's going to get full credit for it. If you are late and you did not tell me before you're going to be late due to whatever reason, life events, you're in the hospital, your mother got sick, that's going on, you moved, you didn't get internet. I mean, I've heard a lot of things. If you tell me before it's due, I can give you extra time. But once something is due, I can't give you any more time. So you'll have 1 more week to hand it in by that next Sunday with a minus 10% deduction, okay? I work with you if you communicate. Again, communicate with me. So attendance, we know you to be on camera at all times. There has been past history where cameras are at ceiling fans, into windows, walls, whatever. But, I'm actually finding the groups that I have, you are really good about listening. And as I told you, if you need to get up, go to bathroom, something you have to do, please go do it. Just come back. I know that you just don't want to be walking around as I'm trying to give you the information that you do need. Now, what I said about working ahead on those different types of assignments, don't post them all at once. Like a lot of people like to do NCLEX questions and throw them all in. I'm going to warn you against that. You can do them, you can save them, but you have to have 2 points of contact in Canvas every week to show attendance to Canvas. The online Zoom attendance doesn't count for attendance, as in this regard. It just shows that you're doing the work in Canvas. So you do your discussion question, you do your peer reviews, guess what? You've got your points of contact. So you sign out and you sign back in and you do peer reviews, okay? Now, if you do not go into Canvas and post something for 14 days straight, they will drop you without notice because you don't look like you're active in the class. Now, if I see that you're missing stuff, I'm going to be sending you messages. Usually on the first week or couple weeks, I'll send you a message. Hey, you forgot your discussion question. Hey, you didn't do your case study. Hey, get your NCLEX questions in. As a reminder, it's just a friendly reminder. Maybe you forgot. I mean, most of you have 3 courses. So I don't want you to say, oh, I forgot, and then hand it in and be late. Well, isn't it nice that a professor would say, hey, please get it in so you get your full credit for stuff. Attendance, you cannot make up. Just like if you were on ground, you didn't go to class, you can't make up. That means quizzes cannot be made up. Now, what if you went to the ER and you're in the ER on class time and you messaged me right away, I'm in the ER, I'm not going to come to class. That is something I can work with and get your quiz at another time. As long as it isn't every single quiz that something happens to you, okay? So just to let you know again, communicate with me. Now, attendance, as I said, I do it myself every single week. And if it's 1 minute late, I will take off 15 minutes increments. If you're 20 minutes late, it's a 30-minute increment that you'll be taking off. Now, if you get up to the point of 20% of attendance missed, they can decrease your letter grade by 1. So if you were going to get an A, you're going to get a B. So as you get higher up, 10%, we'll be letting you know, hey, you're getting close, don't be late. Please make it on time, don't miss another class, okay? And that's what I just said. So how to be successful? Well, there's a lot of stuff to do. I don't care if you have a piece of paper with everything written. I have one of those calendars and I write things all over it. I cross it off as I do it. Whatever it is to keep yourself organized. Remember, your syllabus is your Bible. Where the syllabus says it's due, that's when it's due, okay? You're going to see Canvas. Some of your things, they're going to have it open an extra week. That's that extra week with the minus 10% deduction. Okay, so always follow your syllabus here. That will keep you successful. I also, at the beginning of every class, will tell you what is due when. All right. When you do your NCLEX questions, make sure you get at least a 78 on it. I mean, a lot of you get to the point where you want your hundreds, which is great. But remember, 20% of your grade is subjective. And NCLEX questions are 1.25% for each set of NCLEX questions. And it can affect your grade if you're borderline at the end, okay? So at least try to get that passing grades on them. And you can do them as many times as you want. Case studies, it's only one time. Now, a lot of times you're going to see there's internet problems. I've had students, where they've moved, they didn't have it, or it was turned off. Make sure that during class that you are somewhere where your internet works as best as it can. I can see when you sign in and out. I know sometimes there's storms, etc., that go on. Last semester with, winter more, there was a lot more windstorms and ice storms and all that. If you're seeing this is going on, remember, you have my phone. Send me a message, okay? If you can't get the message to me in Canvas because your internet's down, you have your phone. You can send it through your phone or you can send me a text message, whatever. Just let me know what's going on. Again, communicate with me. I do not put a lot of announcements. I'm not the one who sends you 10 announcements a week. I will send you week 1 information and anything else that you need to know. And then usually week 1 is like 3 different announcements. That's a lot for me. And then you will see week 1 recordings, which will be the YouTube recording. And remember, I do have a YouTube channel. If you do go to it and subscribe to it, it does tell you when those recordings are posted. I've already posted the Monday class. Later on tonight, I will post your class, and it will be in the announcements. It'll say week 1 recordings, and underneath that, I also will put the week 1 PowerPoint that goes with it. I like to put that PowerPoint in with the recording, so again, it's in one place for you because you have stuff all over the place, and I'm trying to help you as much as I can, keep you organized. So this is basically what I was just saying. Now, let's say you're going through this course and you're getting lost and you're not understanding. I don't mind meeting with anybody. If you only have a half hour to meet and it's at this time of the day, I'm going to try to work with you. So just let me know what you need, and I'm here to help you, assist you in any way possible. If you're doing a quiz, and let's say you have one of those internet problems, what I want you to do is not try to sign back in. Immediately let me know, and I can reset it and get you back into it at another time. It could be right after class, doing it. So problems with the internet, whether you're taking exams, quizzes, the best thing to do is stop, let me know right away, okay? I can see every touch that you do, whether it's looking, you put, A as an answer, and then you took it off. Then you put C as the answer, and you took it off, and put B as an answer. I can see all that stuff. So I can see where your internet goes in and out too. Again, tutoring. All right. This class, and how do we score? What's our scoring criteria? Excuse me. You have your exams, your quizzes, and your HESI, and those are worth 80% of your grade. The rest of the stuff is worth 20%. Now, there's one big assignment that's due here, and it's changed a little bit. We made it a little different, makes you think a little more to do it this semester, and it is worth 6% of your grade. It is something on a pediatric diagnosis on a child or virtual child that you choose yourself. Let's say your daughter has diabetes, your son has asthma, somebody has a syndrome, Down syndrome, autism, ADHD, any of these things that you want to learn more about, I would choose those for your pediatric assessment. Now, let's say you don't have anything with anybody, but you really wanted to understand this diagnosis more. Choose it, and then it's a 3-part thing. It's due on week 9. Now, let me warn you about week 9. Community has a project due about there too. I don't want you to be hit with all of it at 1 week, because that's the way it will be if you don't start to work ahead. So in these beginning weeks, as you have less sort of homework to turn in, I would look at it and make a decision and work ahead. Now, what do I do for you to help you succeed on that assessment? Turn it in. I will look at it, give you some critique it. I'll tell you, change this, do this, add this. And if you do it, I will increase the grade that I gave you, okay? So you can, everybody get 100 if you do what I tell you to do, okay? So it's not as bad as it really seems. Now we turn the homework grades off and on, and we do that to show some students who are not turning homework in, how it can affect their grades, okay? And it also shows you who doing the homework, how it really does make your grade can go up a whole point, you know, from a 79 to an 85, you know, so do your homework, do it the best you can. Now, if you're seeing your case studies don't go over into the grade book, it shows a 0, let me know right away. I'll see if I can go in and find it. Now, if I can't, I will tell you to fill out a help ticket, but usually I can find your grades, okay? So in order to pass this course on your HESI, your exams, and your quiz, you must have a 78.0. After you do that, we add in your subjective grades, and your grade still must maintain a 78. Now, I have had what we call homework fails, and mostly because they didn't turn in that pediatric assessment assignment. And I will send you, I can't even tell you how many messages I'll send you. Please turn it in. Remember, it's 6%. I don't want anything bad to happen to you. I'm going to send you messages of the sort, just trying to help. Like, is something going on in your life that's stopping you? How can I help you? You'll hear me sending messages to you to help you. Because the one thing that to fail is, okay, quizzes and exams, because, you know, they're hard. But to fail because the homework isn't in, you know, that's just your work to do to get it done. Quizzes will be given at the beginning of class. It's going to be last week's work. So your first quiz next week will be on this week's information. Week 3 quiz will be on week 2's information, okay? So the week before, you know, and as I go through and do my PowerPoints, etc., you know, if you listen and if you go back and you look at the Kahoots, you look at the PowerPoint, you'll do very well. Excuse me, it's the weather. All right, ExamSoft, we know how to do it. And exams is one attempt. And again, if something happens, you have to stop. Just let me know right away. You know, we have exams that students didn't download or the upload and they couldn't get it. They've taken their exams and 4 days later, we can retrieve those grades. So if all of a sudden, you know, your computer screen turns black, it dies, and whatever, don't be afraid. We still can go back and get your grades from ExamSoft. So just let me know immediately right away. Anybody with accommodations, please let me know. I've already had 2 people contact me. So I've already, you know, written that down. I will make sure that your quizzes get the accommodation, and I've sent the information to Dr. Brown to make sure that the exams also have that, because she's the one that has to adjust the ExamSoft for that, okay? So
I have accommodations.
And okay, could you just send me the letter?
Yeah, I'll send it to you.
Okay, that's all I need. And then I will make sure. Now, exams, we're going to have to do a little differently for you so that you get the proper timing. It could be that you come in earlier or on a different day during the week. We'll do something to make sure that you get your accommodations, which works for you. Okay, those with accommodations. Now, some of you like to do your exams on ground. I need that person from Fortis who's going to proctor you, send me an email stating that they are going to proctor you on ground. Remember, it still must be done during class time. And you must come to class afterwards. So This class is from 3 to 5:30. On week 4 is your first exam. So at 4:20, come back and we'll begin class, and then you'll get your attendance, your full attendance, okay? But the thing is, I have to know at least 3 days before so that we can coordinate and I can get those access codes to those people that are going to be giving and proctoring your exams. You know, the exams are like always, you have to be on camera, you're going to show your ID, I'm going to look around your area, you know, nothing in your ears, no iPhone watches, you know, none of that sort of stuff. And make sure that you have a whiteboard, a blackboard. They're really frowning against pieces of paper. So what else could you use? Well, I've had students use gallon Ziploc baggies and put a piece of paper in it with a dry marker, and you can write on it and wipe it off when you're done. There's very creative ways that you could do in order to get what we need, an erasable something when you're done with the exam. What happens if you can't make the exam for whatever reason? I need to know before the exam again, okay? Don't tell me after the exam that whatever reason. Most times, you know, before you're going to go to class that you're not going to make it. And if it's an exam that day, you probably know. Again, communicate, let me know, tell me before, and we'll work on another time. If you just don't show up and don't take, oh, I forgot, or I was trying to get internet or whatever, that's going to still be a minus 10% deduction on an exam. And that's a lot of points. These exams are very comprehensive. They are hard, but you don't want that 10% off, okay? You want to get every point you possibly can. Exams must be, if you miss it, must be done within 7 days. So this is a Wednesday class. By the following Tuesday, this exam must be given and been done, okay? Again, contact me. I'll tell you again, talk to me, communicate with me. It works. So again, plan your time, know your syllabus, know what's due, and get yourself organized. It's really important. I do send messages. So if you see something that you didn't get full grades for, I mean, your discussion questions and your pediatric assessment assignment, I'll write little notes in there, follow them up, and we can work together. That's another way that looks like my calendar that I have. We've already talked about late work and NCLEX questions. The first week of NCLEX questions are on growth and development. They're just not on pediatrics. Make sure you go into the module and it will tell you what area you need to cover. And growth and development is a separate section from pediatrics, okay? So make sure you do the questions there. On your first discussion question, it's tell me about you, but it also talks about nutrition, the importance of nutrition. So make sure that is in your first week's discussion question also. When you send me the NCLEX questions, make sure that I get those 5 or 6 pages. That little green box, I can't accept it. I need the whole printout. If you don't know how to do it, I have a instruction sheet I'll send you, or I can, get online with you and show you quickly how to do it. It's actually really easy. But if you don't know, I will show it to you, not a problem. And again, get the best scores you possibly can. Case studies, etc. Again, they must be done through the modules. It's one time. Again, if you see a 0, just let me know. And I can find out what's going on. And if we have to do a help ticket or what do we have to do for that. And the papers, etc. Again, it's APA. I will be sending you some APA information so that you can follow it so that you get your best grades possible. I'm not overly OCD on the APA, but you must have references in there. You must not just copy and paste from a resource. Put it in your own words, please. Again, always follow the rubrics. And again, try to get those references 5 years or less. It just shows you the new evidence-based research that's out there. Again, exams, quizzes. Again, the quiz is through Canvas. So you'll go through your module, quiz 1, and it should be ready to go. You come in and you only have 15 minutes for it. Again, we're going to do an introduction into that week. We're going to do the quiz, and then we'll start with our class time. Again, any problems, stop immediately, let me know. That's why you have my cell phone number. I don't want you trying to get in and out and get frustrated. Number one, you're not going to think, you're not going to do good. So just stop and just know that I can restart a quiz or an exam so that you cannot be stressed out because, oh my God, it went off and the computer went, I don't know what to do, and time is running and I can hear your minds going. Don't do that to yourself. Just let me know right away. HESIs mostly now are going to be given on campus. We used to use ProctorU. I don't know if we're going to be using it. I think only in extreme emergencies. So we're trying to get everything on campus. After the HESI, you do have the remediation, and that's due by the Monday of week 12. And then by Tuesday, you're going to be having what your final grades are. Again, the remediation hours, I'll be putting that in an announcement closer to the HESI so that you do have it. Again, always be online, always have your face here. And here's some questions to just ask you about, relating being professional, on time, and visible. I mean, it's who you are as a nurse. I mean, you're always going to be visible to your patients, and if you're not, they're going to be on the call bell calling you. Like, where's my nurse, right? But if you show up every now and then, say, I'll be back after this, those students will not bother you. Those patients will not bother you, right? And that's what I used to do. And they got the best of care and they felt comfortable and they felt safe, which is what we want to do. Any questions? All right, let's go to the next thing. I apologize for my voice. It's the weather. And the one thing you're going to learn is rheumatoid arthritis affects joints. And there is a joint in your voice box. And that voice box on mine is one of the only ones that my rheumatologist has ever seen where my voice just goes really scratchy. And it sounds like I'm sick. I'm not. It's just an irritation, a swelling, the inflammation of rheumatoid arthritis. So I'm on infusion, so I just have to wait till the next one, which is next Tuesday. So hopefully my voice next week will be better for you. So let's start out with chapter 26. Has anybody heard about healthy people? Anybody? Ever hear of it? When I went back to nursing school, get my upper level degrees, I had no clue what healthy people was. But basically, it's a lot about the first ladies. They have about reading, nutrition, playing outside, reading books. It has to do with a lot of things. They've, bettered the nutrition in your school systems. I mean, it's still not perfect, but they're trying to make the school lunches, breakfasts better, etc. Well, it's a government thing to look at disparities, healthcare disparities, and trying to improve them. And these are the things that we see in children, their family, growth development, mental health, and nutrition by far is the most important thing on children. I mean, just think about a baby is born, they're born at 7 pounds. They can't lift their head. By 1 year old, they've tripled their birth weight, and a lot of them are walking, or at least starting to walk. Isn't that a lot of change and growth in 1 year. And that's all because they've had proper nutrition, which has fed their brains, their nerves, their muscles, and has given them what they need to grow and to be healthy, okay? So nutrition, huge in pediatrics. Now, another way nutrition bothers us is obesity. Well, today we have an electronic world where children love to be watching TV, playing games, and everything besides being outside and playing. You know, when I was a kid, I'd come home, change, get on my bike and go. It's not like that today, but it also depends on the neighborhood where you live too. So that could be part of it. Health problems is childhood injuries, and most of them are unintentional, things that just happen. They fall off of bikes, you know, they climb up. I think the worst unintentional injury I've ever saw was this little 2-year-old kid was climbing up a dresser of drawers with a TV on top, trying to turn the TV on, and it wasn't attached to the wall. Guess what happened? The TV fell down on the kid's head. It was not a great outcome. So childhood injuries are huge, and not because they meant to. It's just, this is when they were just saying, like with IKEA, giving you those little things to strap your furniture in. It just started at that point. It's about 10 years ago now. Violence always could be even bullying. Vaping, you know, the teenagers are into vaping and vaping whatever they're vaping, you know. And mental health. Children do have mental health issues. I've seen children very schizophrenic, paranoid, depressed. It's very real, even in very young children. So picture says 1,000 words, right? Gun violence, you know, suffocation, swimming. Now I live in South Florida. I've seen a lot of drownings, okay? That's why my grandson knows how to swim already and will not put his foot in the water unless he asks one of us first. He knows better. He did it one time. He got picked up, thrown on timeout, and my husband was yelling at him, "Don't you ever." Well, he was so scared, he will never do it again. You know, frying pans, stoves. I have a brother who, for his life, had a big burn scar on his arm from going up to the stove. And we know they're always getting into pills. Most of the time, they like their vitamins. And actually, vitamins have no iron are actually more benign. Is when you get into the Tylenol, which is liver toxic, right? Those are the big things. So health problems and the child. Now, kids have normal things that they have problems with, but the one that you see the most problems is those children who were born premature, very low birth weight, or low birth weight. These children have all of these problems with fragility of brains, and they have brain bleeds and problems with their lungs and surfactant, and they become chronic lung type children requiring oxygen and requiring extensive pulmonary care. I mean, this creates a lot of health problems, you know, really susceptible to infection. And we have children that are, you know, poverty, homeless, or like steps from being homeless. It's a reality. You know, I live in South Florida, Homestead, where there's a lot of land for agriculture. And we do see a lot of Mexican immigrants here. I'm telling you, I get a Mexican immigrant mother in with one of their child. That's going to be my sickest kid in the whole emergency room. My last job was working in the emergency room. And they are afraid we're going to deport them. So they come in and they've already gone to, you know, they're a person who treats them within their group. They've gone to the clinic that, you know, minimal care. And finally, they come to us and they're really, really sick. So it's a big reality, this. If they have these chronic medical psychiatric illnesses, disabilities, you know, how do we get there? How do we pay for it? You know, and a lot of the barriers is, you know, I don't even have a car to get there. You know, I don't have the money to pay for a deductible. I don't have money to pay for a taxi, a bus. Now, the first 28 days of life is called your neonatal period. After that, you're an infant. So the number of deaths is in children, in infant mortality, the first year of life is higher than most other countries. You have Switzerland, you have some of these, Norway, they've got really good survivals, but we're not there yet. Now, I could tell you, I started newborn ICU back in the 80s, and the changes that have been made are significant in order to make the care better. And survival rates are so much better than they used to be. We know that a smaller child is going to have more problems than a child born of a proper birth weight. As they get to be older, the death rates are decreased. Usually now it's just unintentional injuries that occur. And we know that as they get to be an adolescent, all of a sudden death rates go up. You know, they tend to be, I'm old enough, I'm going to try it. You know, injuries, they don't think before they do. Homicides, whether it's intentional or not. And yeah, adolescents are all about body image, what they look like. I'm too fat, I'm too skinny, I have pimples, my hair's too curly, it's too red, it's too whatever. And they get into this body image and they feel rejected. Suicide is huge in adolescence, and also gun death with violence. So what the groups that we see increase mortality, we've gone over them. Homeless, poverty, low birth weight, chronic illness, foreign adopted children. We don't know all their illnesses they have. And then children in daycare centers. Well, why would that increase morbidity? It's because what do kids do in daycare? They play with toys, right? And where do the toys go? In the mouth. And what does the next kid do? Take it and do what? In the mouth. So they're what I call swapping spit all day long. And it's nothing you can do about it. It's actually good and bad. Like, at least they're getting all of these chronic illnesses, building up their immune system. But what if they get something that is more serious? So it's a two-bladed sword here. So pediatric nursing. One thing about pediatric nursing, you're not just taking care of a kid, you're taking care of the family. That means you have mom, dad, then you have grandma, grandpa, aunt, uncles, and depending on the culture that you're working with, you could have 9 people in a room for one child in the emergency room who came in with a fever and a sore throat. You could, and they're all family. Remember that family is the only constant in that child's life. This is what they know. This is how they act. This is the way they've been taught. It is the only concepts there. And remember, a family, they're all different. You know, when my grandson was born, it was my daughter, me, and my husband. That was his family. Well, now, thank God, he has a really good father, a father, and a mother, you know, and, you know, it's that normal life. I mean, we have blended families, everything, but remember, a family is whatever they say it is. Now, pediatric nurses, you know, we are in the in-between of husbands and wives, especially when you have really serious diagnoses. I found this a lot in the cardiac ICU. A lot of these children are born with congenital heart defects, and the father's blaming the mother and the mother's blaming the father, and, you know, divorce is really rampant, you know, for these really chronic children. Nurses are that go-between, in between. We're that advocate, okay? We're that caring person. I mean, besides that, what do we do as nurses? Well, we're teaching, whether it's health promotion, whether it's disease prevention, or it's just teaching them not to have injuries. Anything that we need teaching, we're going to be teaching these parents. So pediatric nursing. Well, How many of you have children that are afraid to go to the doctors because they're afraid they're going to get a shot? I mean, you're going to, yeah. I mean, there's quite a few. One of the things that as a nurse saw is we have these children in the South Florida in the emergency room where they're going into the room, no pinche, no pinche, which means I don't want a shot. Don't give me a shot. They're just afraid of them. Well, why are they afraid of them? Well, that was my dissertation for my PhD. So what I found out, which helped with decreasing the amount of stress, fear, and pain, is I have the parents or that caregiver hold their child for injections. It's called Huggies, H period, U period, G period, an acronym. Help us give great injections efficiently and safely. And our hospital system down here, they use it. Nicholas Children's Hospital, urgent cares, everybody uses this program. And through research that I did, I found out the kids did better during and after injections, as evidenced by less crying. They weren't upset because mommy was holding them. So by the time they were upset, the injection was given, it's already done. They're already in mommy's arms. So it really works well. So we're looking for that atraumatic care. We're using numbing creams. We're using distraction. We're doing everything to try to help this child not be afraid of what's going to happen. Children from a young age understand, and they need to be taught on their level what's going to happen. And they really will help you, but you've got to get it on their level, okay? Because if you go in every time, take the kid with another nurse, a mom, hold them down in a stretcher and give them an injection in the arm or in the leg, guess what? That's all they're going to know. I'm held, and they don't like the lack of control of laying down and being held. They can't stand it. In mommy's arms, all we have is another nurse hold the leg, if they were doing that on the younger kids, just to make sure they don't move, and we give it and it's done. And it's really not a big deal. And these kids are not going to be that one who's running out of the ER with me yelling, security, get that kid, and he's running across the parking lot. And that's what they do. And that's reality. So my goal in doing this program and this dissertation was to find out why school-age children were so afraid. And a lot of it had to do with their holding me down. And they just wanted to be a part of it and know what was going to happen. And nobody taught them. So now with the institution of Child Life, which lets them touch equipment, feel equipment, we explain things to them. We're not going to show them a needle. Don't get me there. That I'm not going to show them. But we're going to do a little touch here, and you're going to feel a little ouch, but it's gone right away. And the kids do really, really a lot better. And as we go now through next week, infants, toddlers, and preschoolers, I'm going to show you some ways that we do that. I'm going to go in a little bit more to that. So family structure, there's all different ones, like I told you. Moms and moms and dads, and I have my children, he has his children. There's all sorts of things that are there. Remember, a family is whatever they say it is. Now, the one thing about, as a nurse, you have to find out who's in charge, who knows the information, who you're going to get that information from. Because you might have 4 different people trying to talk, and you only need one person to tell you what's going on. We know that there's a lot of different cultures and a lot of beliefs and a lot of things people believe, and it's hard to understand. I know my background, my culture. I don't know all the cultures. I mean, when I first moved to Miami, there was hardly any different cultures where I was from. So I had to learn about Hispanic and Haitian and Mexican and Cuban and Puerto Rican, and I could go Jamaican. I didn't know any of this. And there are different beliefs in the way they believe, okay? Okay, a frequent health problem of migrant children and adolescents in the United States is So migrant children, come here. What's something you see that we don't see here in the United States much?
Tuberculosis?
Yeah, it's tuberculosis. I mean, because they're not getting tested as much and they're not as aware as much, depending on the country. All right, let's look at some more. Look at cultural beliefs. Now, there are cultures that believe that you should wear different clothing, different medicines. For instance, my husband's Jamaican. He believes in ginger, garlic, honey tea when you're sick. They also have these poultices that they put on them that heal stuff. You have people who believe prayers. There are some cultures that pray 6 times a day. What do we need to know as a nurse about that? Well, we need to give them the opportunity to practice what they believe in, right? What about the cultures who believes if you have wet hair, you can't go outside. You can't go to bed with wet hair. You're going to get sick. Or if you go outside and get wet, you got to dry off. You're going to be sick. That's why you're sick. How about, now, this is the one that used to, I didn't understand. You have a kid come in and they're Hispanic and the grandmother comes in. Now the grandmother is always in charge, an Hispanic type of family. My children are both Cuban, half Cuban. So I know this for, upfront and personal. Anyway, kid has a fever. What do they believe in doing? They put hats on, sweaters on, socks on. They believe in covering them. They don't understand that if you have a fever, you should take clothes off and let the fever go away. Well, one of the things they don't believe in is allowing children to walk on the floor with bare feet. They think they're going to get sick walking on the floor with bare feet. But what if the kid is sick with a fever? Walking on that cool floor with bare feet is going to help keep that temperature down. So I used to have to teach abuela, grandmother, let him walk without socks, please. And please don't cover him up because the fever's got to get away. So these are some cultures that I have dealt with, and you're going to find so many out there. Just be aware that some of them believe that they did something wrong, so the kids being punished because of what they've done. There's all different cultural things that you're going to learn. Just have your mind open to understand these things, and try to help not only the child but the parent. Another thing that I have worked closely with is things like giving children baptisms, etc. I've done it for all different reasons. Whether it's a rabbi, a minister, a priest, it doesn't matter. If that's what they want, I'm going to make sure that I get somebody there who can get somebody in if they can't get their own person in. One of the things that I've worked with is Jehovah's Witness and blood products. Now, when I worked in the newborn ICU, remember, infants don't start making their own blood till like 3 to 6 months out. And blood dies naturally. Also, we're taking blood to monitor electrolytes and etc. Because we're giving them hyperout lipids, or we're feeding them. We're making sure that their electrolytes are okay. So we're pulling blood out of them. So their blood counts are getting lower and lower. And it's not being replaced because the body doesn't have that ability yet. It becomes a point where their hemoglobin and hematocrit are so low, they become symptomatic. Hemoglobin of 6, hematocrit of 18, really low. Symptomatic, what would they show? Periods of apnea and bradycardia. Now, Jehovah's Witness does not believe in giving blood. Has something to do with the soul of the body. They don't want somebody else's soul being placed in them. I don't know exactly, but I know that there is a conflict and they firmly believe. Now, we will get a court order to get it done. But as a nurse, what are you going to do to respect those parents' wishes? Well, the child is our first primary thing that we're going to worry about. The child needs the blood, but I don't have to take that blood bag, bring it in and show it to the parents. I worked a lot of night shift. I would send them home. I'd say, call me back at 1 in the morning and I'll be done. And I'll tell you everything went. They never had to look at it. I've done it on the day shift where I put the parent out of the room, pull the curtains. I would take it, draw it up, put it on the child. Then I'd cover up the IV tubing and everything so they didn't even have to see the blood going in to the child. So it was being given, but it wasn't in their face. I was being respectful. You know, I had a child, one of the last children I saw in the emergency room before I stopped working just to full-time teach. It was a kid who was a Jehovah's Witness. It was a very bad heart. He had a hypoplastic left heart, really severe one. And I had to give him blood. And the mother's been looking for me for 12 or 13 years, trying to tell me, thank you for the way that I gave that blood, that I covered it and I respected her culture and her wishes and didn't make her feel bad. And it really made me understand why I need to tell you all about this, because just that little simple act of covering it gave that parent such a sense of relief that she didn't have to see it because they don't believe in it, okay? So culture does play a lot. Again, we know that everything we do is under research, evidence-based, and you know, a lot of us, we're just teaching. So leading cause of death among African-American boys ages 15 to 19 is what?
Suicide.
C.
A, the firearm.
Yes, it's the violence, it's the firearms. Whether they're say, well, I can touch it now, I'm old enough and it goes off. Or remember when we're getting at, maybe it's the gangs getting together with the wrong crowd. Could be any of those things going on, but it is firearms. Okay, health promotion. I mean, look at what happens to us. We go from, as my daughter calls it, a peanut. We have a little peanut still in my refrigerator from my 6-year-old grandson. And they grow up and we grow into old people. And it's amazing how many things have to be done for us to get there. It's interrelated, simultaneous, ongoing. We go from not being able to pick up our head to taking a couple of steps by the end of the first year. And that's quite amazing. And as long as we're moving forward in our development, we're doing good. There's a couple different things that we can measure. You know, quantitative is something we can look at, we can see. And that's why we do height and weight every time you go to the doctor's office. It measures nutrition. It measures things like growth hormones. It measures if that thyroid is working properly. Many things it looks at. And then the qualitative is more of how they're starting to understand more. It's a more subjective thing to think about. We do maturing, means we're thinking on a higher level. And an example would be, give an infant a rattle and they do a reflex grasp and they grab onto it. And all of a sudden they move their hand and they hear a shake and they hear that noise. They're like, ooh. So cognitively, they're like, if I shake it, I'm going to get that noise again. And oh, I like that. This is part of cognition and learning, because when they just held that rattle, they didn't know that. But after they moved, they figured it out. And when they moved it again, it showed that they understood. These are things that children do and how they learn. You know, there are patterns of growth and development. Directional is head to toe. Sequential is how you do your motor sort of things, lifting the head, turning from your abdomen to your back, back to abdomen, crawling, creeping, that's all sequential. Developmental pace, are they doing the things they should? Are they reflex grasp? Are they pincer grasp? Are they making little blocks? All of these things we'll be talking about a little bit more next week when we get to infants. And we know every child is different. No two children are the same. They all go through their own way of doing it. Their metabolism matures as they get older. We know, I've given you a handout. If you look at it, and neonates, heart rate and respiratory rate is 140, heart rate to 160. That's fast, right? That's normal at sleep for an infant. Now, if that was an adult, there'd be a problem, whether it's, dehydrated or a fever or shock. Could be a little bit of all of them. As they get older, those numbers will come down. And by the time they get to be an adult, we know it's 60 to 100, right? Even blood pressures do the same thing. Temperature, initially, they can't regulate temperature. And that's why they need to have an extra blanket on or an extra t-shirt on at home. Sleep, rest. They sleep a lot as infants, hopefully, right? They usually just eat, they drink, they pee, they poop, they sleep. Those are the things. Repeat, repeat, with a little bit of tummy time in between. But as they get older, they're awake more and more. That's part of that sleep and rest. Again, nutrition, nutrition, nutrition. The single most important influence on growth. It's because it's feeding the body so it can grow the way it should. A child who's not getting proper nutrition is not going to do all of the gross motor and fine motor things that they should. They're not going to be able to lift their head up by 2 months. They're not going to be able to turn over by 6 months. And that's something we need to look at. That's why we look at height and weight every visit. Are they gaining weight? They're gaining weight. They're getting the proper nutrition. And we know kids are all different. Some kids will go to anybody and some kids will go to nobody. And that's just part of being kids. Now, I'm not going to go into all of the theories today. I'm saving that to next week when we start looking at infants, toddlers, and preschoolers, and I'm going to give you those examples as we go. Some of the things with Freud is all about psychosexual, all right? Oral is everybody at birth, everything in the mouth. How does a child explore the world? In the mouth, always. Move it around in the mouth. They touch it, feel it in the mouth, move it around. Sensorimotor. Erickson starts out with just, you have an infant, cries, you go in and you pick them up, you change them, you feed them, you burp them, and you hold them. That's the trust that they build up. The mistrust would be nobody goes and they leave them crying. As simple as that. And we're going to go into all of those. And Piaget is more about the thinking. That's more about grasping the rattle and holding it. Cognitive awareness. Learning that if they shake that rattle, something's going to happen. Or pre-operational. You have a kid in a high chair and mommy goes into the kitchen or somewhere and the kid wanted mommy there with him, talking to him as he's eating. He'll take his sippy cup, throw it on the floor, loud enough so mommy can hear it. Because what does mommy do? They go and they pick up the sippy cup and mommy's back to where the kid wanted them. They have already learned how to get mommy back to where they want them at a very young age. So language, they are born with the ability initially to coo and to cry. Those are the first two things that they do. And then they start learning everything else that they understand. If they cry, somebody's going to come. This is all about learning and being that cognitive awareness. Goldberg is about right and wrong, good and bad. And it gets to the point of wanting to do right and not doing wrong because they want to please. So we're going to go look at those areas too. Now play. I've always said I went to work every day, even if it was a very serious, kids crashing, traumas coming in. I still went to work and I played every day. I had children that I got to love. I got children there that I could work with and I got to play. Now, children play, right? It's part of their initial first couple of years of life. They play because it teaches them how to work with another child work alone, and how to make things work. So being aware, making that car move, put the ladder up in the air and extending it, pushing the buttons, whatever it is, it's really good for their learning. So there's different types of play, which you should know. So social, affective, you're playing with another kid. That's it. Sense pleasure, when you touch the toy, like sand in a sandbox, right? Or water in, the pool, that you put water in a bucket and pushing it around. That's sense pleasure. Skill play. This could be putting blocks on top of each other, as simple as that. Unoccupied behavior, you're alone. And then you have dramatic or pretend play. Dramatic play could also be used when we're trying to figure out if something happened to that child, like some sort of neglect, usually something, some touching that shouldn't have been there. And if we give them dolls and toys, they can reenact it and we can figure out maybe if something did happen. And we know that there's games, there's checkers and all sorts of things that the kids play. The sensorimotor development, again, plays. What does it do? We touch it. We put it in our mouth and we move it all over. I mean, this kid's playing with paint and it's in his mouth and everywhere. I mean, it's just part of what they do. It's part of their development. They're making their mind, their cognition work. When they're with other children, they're being social. They're being creative. Like this kid was putting that all over the place. He's being creative and painting things. Well, we may not like it as parents because we have a mess to pick up, but the kid benefited a lot from it. They start to be aware of their hands and their feet because they have stuff on it, right? And it's something that every children should do. Now, these are the type of plays. Onlooker, I'm looking at somebody else play. Solitary play, I'm playing alone by myself. Parallel play, I'm playing next to a kid, but I'm not playing with their toys. I'm playing with my toys. We're just next to each other. I'm not paying attention. Associative play is when you have a bunch of toys and two kids are playing with the same toys, but they're not doing anything together with them. And then cooperative play is when you work together and there's a goal. I could describe that as let's play some checkers because there's a goal when somebody wins, right? Or let's take in this buckets in the sand and make a sand castle and we'll put a flag on top when we're done. As long as there's a goal in the end, working together, that's cooperative. Toys help with their movement. You're putting toys in front of them. They're gonna know that these toys are there. They're gonna try to, wiggle, try to get to them, and you're making their muscles work. And you're, making them, being able to get it. And then they get the toy and they can shake it and rattle it or whatever they want to do with it. It really helps with their muscle development. As we are looking at children, and we looking at what they're able to do, we're basically doing developmental assessments. And there's all sorts of screening procedures. There's screening procedures for children that should be on the normal, rainbow of things. And then there's children like this child down here on the left. She looks more like she has cerebral palsy. There are checklists for her too. And I'll tell you, children with cerebral palsy, they know what's going on. Their problem sometimes is they're nonverbal and have the inability to express it verbally. But by their eyes and their facial movements, they know you're there. I mean, one of my favorite kids when I did clinicals was little Jonathan. Now, Jonathan, 7-year-old CP kid, nonverbal, and he couldn't walk. He was in a wheelchair. He would see me across the room and the smile would go ear to ear. And he was so spastic, but his hands would come up like he knew I was going to come and give him a big hug and he was waiting for me. So they understand a lot more than you do know. So I always treat these kids they're all normal to me because you treat them like that, you're going to be surprised what all they can do. Children can be born with many different things. I mean, we know that there are syndromes like Down syndrome. There's other things. It could be problems that caused by drugs, normal drugs, cocaine or alcohol, but Dilantin, Coumadin can cause some sort of problems with development. And then we have things like cleft lip, cleft palate, club foot, all of these things. I've seen missing fingers, arms, legs, one bone and legs, all these things, congenital abnormalities that you're just born with them. So many times genetic factors do cause these problems. We know that Down syndrome is due to a problem with, their development, and it's, you'll see that number 20, 18 usually are the chromosomes that are affected on them. Now, as we see those things, sometimes they're subtle, making sure we work with the parents, we work with the physician, and making sure that these parents get the education, the care, and support. I mean, there's a lot of sort of programs available. The one thing about kids, if they're behind, when we see that they're not, doing all the milestones where they should, and they're definitely behind, we can institute early intervention. And with early intervention, many of these kids, we can catch up really quickly. So as quick as we start early intervention, the quicker it can get better. And again, all of these things can cause problems. And this 22 chromosomes, there's a Q22 deletion syndrome, and that's called the George. And it's just one of the ones that I've seen through my career. Again, nurses, what do? Well, we know some of the genetics, we know what's expected on the child so that we could teach parents. A lot of these parents feel guilty that they have these children that they didn't know before birth. Again, we need to make sure that these parents do bond with these children. Many of these things are not their fault, and especially when I had cardiac children, they feel like, well, was it the aspirin that I took, or the Tylenol? Was it the glass of wine? And you need to say, no, Mom, it wasn't. These are things that just happened. And they really do feel guilty. So making sure you're there for those. Now, there's all different sort of things: object permanence, pre-operational thinking, concrete operational things. These are different things. We're going to go over it a little bit more next week, but let's look at what those things mean. Object permanence is when I have a rattle, I put it behind the stuffed toy, and the baby can't see it, but the baby saw me put it there. And the baby goes trying to crawl to get it because they know it's still there, even though they can't see it. It's object permanence. The 1-year-old kid, you take his trucks, put it into the toy box, walk away. The kid's going to go over to the toy box and get it because even though it's not in sight, they still know it's there. That's object permanence. And we're going to go into pre-operational concrete, and that we're going to go into Piaget. And again, we're going to go into that next week. It's a lot of theory stuff next week. So history and physicals. Now, when we're talking about HIPAA, remember, an 18-year-old can sign for themselves if they're cognitively aware. So a mother and a father cannot get information on their 18-year-old son or daughter. The son or daughter has to give permission for their parents to get that information. Remember, that's a big thing with these children. They sign for themselves and they have to give the okay. Now, as a nurse, you're going to be talking to parents. Now, you want to encourage them to talk, but make sure that you're focusing the focus on why is the child here this time. I mean, you have some parents that'll come in with a notebook and they'll start telling you from birth. And if the kid's 6 years old, 3 years old, I don't need to know every little thing. I just need a couple things from them. Again, when you're talking to them, Find out, who are you going to talk to? Now, was this child with grandma all weekend and she knows all about the fevers? Or were you the person there? Because instead of asking questions back and forth, you ask one person. And always with effective communication, you use silence, you're empathetic, and you just want them to tell you what's going on. If this person does not speak the language that you speak, make sure that you do not use a family member. The family member will interpret it in a way they understand. So make sure you use that blue phone or somebody else in the medical field. With kids, there's always you can talk to them, but number one, you need to get down on their developmental level. You need to start a rapport. And these kids, after you do that, you could do all sorts of things like, where's your ears? Where's your eyes? Do play, and having them play with equipment. And all of this stuff will help them communicate and show you things, show you where they hurt, et cetera, et cetera. Again, go to the informant. What's going on this time? What are the signs, the symptoms? When did it start? Any medications? Have they had immunizations? Is very important, because if it's upper respiratory and they've had no type of immunizations, it could be something like pertussis. So you need to protect yourself and you need to protect other children. Okay. So history, a quick birth history. Was it a vaginal delivery, C-section? Were they in the newborn ICU post delivery? Those things are important. Eating, what are they eating? Breast milk, iron fortified formula, or are they eating a normal diet of everything? As you get older, you're going to be asking those adolescents about sexual history. Many times I'll have the parents leave the room, because a lot of kids are not going to tell mom and dad they're sexually active in any way. It could be that little girl who comes in who's having chronic urinary tract infections, and it could be due to some sort of sexual manipulation. She's not going to tell mom that, but get mom and dad out, you speak to the child, get comfortable, get on their level, make them comfortable with you, and then you can ask those questions. And many of them will be honest. In fact, a lot of them are going to tell you things that are going to try to shock you. So try not to be shocked, because they're doing things that, like, what? You're 14 years old, but you can't do that. You've got to maintain that professional, environment and let them talk to you so that you know how to treat them. And you do not have to tell the parents what they said, unless it is something that could hurt themselves or hurt somebody else, okay? So if there's no harm, you don't have to tell the parents. I always like to know about school, how they're doing. It really tells me a lot about a kid. Are they all A students, or they're C's? Or, do they like school, don't like school? There could be bullying, all sorts of things going on if they're not having, those where you want them to be. Unusual habits. Do they like to suck their thumb? Well, if they like to suck their thumb, am I going to put an IV in that hand with that thumb? No, I'm going to put it somewhere else. What if they like their certain teddy bear, or they like a blankie? Well, if they're crying, the parents aren't there, guess what? I'm going to get that blankie and that little stuffed toy and give it to them and go, look what I got for you here. And they're going to be happier. They're going to self-soothe, right? Or do they like the pacifier, or only that one pacifier that you can't find anywhere? I mean, find it, or, whatever we need to do to help those children. Looking at the parent-child relationships tells you a lot. I mean, working in the emergency room the last 10 years of my career, I saw a lot of parent-child relationships. Now, number one, you have to realize that parent brought the child to the ER because there's a problem. So there's concern. Many times, though, they come in, put the kid on the stretcher, they go up to those little black ear things, they're throwing them all over the room. They open up the drawers, there goes alcohol or gauze all over. And the parents are there on their phones or watching TV. So do they really have control of their child? I don't know. Especially if I have to give medications, it might be a problem. If they're admitted, you really need to know what they eat. You know, what is their formula or what is their food? Many of cultures are only vegetarian or no pork or no beef or whatever it is. So you need to know what sort of diet. And if it's something that's restricted, make sure we get it evaluated with a dietitian. Now, examining a kid, you cannot do head to toe. It's not going to happen. You're going to do it as the kid lets you do it. Now, you have an infant asleep in mother's arms. I'm going to go in and listen to the heart sounds, the breath sounds, and maybe some bowel sounds. The kid's quiet, they're sleeping. You can't do that when they're awake. And then as they wake up, I might do some other assessments to them. So you get it as you can, because the kid's going to be screaming and yelling for mom, and you don't want that. But you need accurate breath sounds. You need accurate heart sounds in some cases. So these are little tricks that you do. The one thing is, if we're going in there and holding that kid down and trying to listen to them, whatnot, that kid's going to have such mistrust. But if you allow that kid to stay with mom, many a times, you know, you could do distraction methods. I always had stickers in my pockets. I had boy stickers and girl stickers. And let me tell you, the kids would leave with stickers and they'd be happy. And I got everything I needed from these children, because I'd say, all right, let's do this. Okay, you like Batman? Here, have Batman. You've been really good. You listen, you know, and it does help, those things. Again, examining that kid, like I said, you're going to get on their level. You're going to let them touch equipment. Again, that positioning, as much as possible, is going to be in those parents' arms. Those growth measurements, we know that they're important. As I said, growth, the height and weight tells us a lot of stuff as they get older. Do you know when you could take a radial pulse on a young child? What age? You can't do a newborn. You have to do apical. 2 years old. They say you can't do a radial pulse on a child till they're 2 years old, okay? Up to that, it's not going to be as valid. They say only apical pulse. Blood pressure cuffs are all different sizes. And the one thing about a physical assessment, there's two ways to look at a kid: well appearing and sick appearing. And kids that are well appearing, they'll be talking and yelling and running around, and they look okay. Sick appearing, they're going to be sitting there and not moving, and their color's going to look crappy. You can tell what kid needs your attention right away. We're going to be looking through everything as we can. And again, it may not all be at one visit. We might have to come in and out of that room, but we'll get the assessment as we can. Now, in OB and maternity, they tell you that you do a rectal temp at birth on the infant to measure an accurate temperature. You're actually measuring, do they have an anus? Do you know there are times where infants are born without an anus? And that is a medical emergency, right? We need to put a place where all the secretion's going to. So we have to have a colostomy made on those children. And they usually can go and make an anus, but it's a couple stage surgery to do it in order to get it back to where it should. Head circumference, we do them when we need to. Now, newborn infants, we're going to be doing it every day as our assessment. As they get older, it might be on the kid with hydrocephalus, or a kid who's had, you know, hit their head injury, or it could be a kid who had ventricular peritoneal shunt, something to do with the head. The abdominal circumference, we're going to be doing, and the chest circumference on those kids to make sure whether they're feeding correctly. The chest and the head, we know at birth, the head is bigger than the chest. About a year and a half, 2 years old, the chest and the head should be the same, or the chest should be bigger. Now, if the head is still bigger, there's a problem. Is it hydrocephalus? Is it a brain tumor? What's going on? Now, taking a measurement of height, you think it's no big deal. Think about this little kid taking this big board and bringing it down on their head. They think it's going to whack them and hurt them. So I play a game. I put myself up there and I hold it. I said, oh, let me just touch my head. I said, okay, let me turn around. What number do I have? I go, look, I got a 7. Let's see you. Let's try you now. Now you hold that board. You tell me when you get it where you need it. Can you feel it touching? Okay, back up for, where you need to. I'm like, oh, look at your number. You got an 8. You beat me. Yay. Now, this kid will never be afraid of getting heights again. Because sometimes, we forget and they do whack. And these kids don't forget. And they don't like to take a height, believe it or not. As I said, blood pressure cuffs go from 00 to 1, 2, 3, 4, 5, 6, small adult, regular adult, extra large. So you've got to choose the right blood pressure cuff. So which one do I choose, right? Now, where do I take the blood pressure? Now, tell me, do you really like to take your blood pressure on your arm? Doesn't it pinch? Doesn't it hurt? I think so. I like to take the kids, your toddlers and your preschooler, I like to do it on the lower leg. And it's still an accurate, valid blood pressure, but I can distract them. It doesn't hurt as much. And I'm still going to get my blood pressure. And I let them push the button so they can show me that they know how to take their own blood pressure. Again, playing a game. All right, and pain assessment. Now, kids have been notoriously passed by given pain management. You don't feel that kids really hurt. A lot of times they're not going to tell you they hurt because they don't want to take the medicine or they don't want a shot. They're not going to be, I don't hurt. No, don't hurt me. Many times it's also that we don't go in and evaluate it. Now, back in the early 2000s, the Joint Commission said that the 5th vital sign was on pain. So now we have to ask, or we have to look at children and see, are they in pain or not? And there's ways that we can do that. So we know that there is the one thing here that we use a lot is the Wong-Baker faces. And I'll show you in a second what that looks like. And the numeric, those are 2 ones there that are used a lot. Anyone can be used. And what it does is they can tell you from 0 to 10, how much pain are you in? 0's no pain, 10's the worst pain in the world. Kids don't lie. They tell you exactly what it is. Adults will exaggerate, not children. Numeric, according to your book, is used by children 8 years and older. Now, have I used it in younger kids? Yes, but your book says 8 years old. Now, how do we measure pain on a nonverbal child or on an infant or a kid younger than age 3? Well, there's something called a FLAC tool, which is, let's look at the face. Are they grimacing? Okay, you can see those little, eyeballs in, or are they not moving sitting there because they hurt? Or are their legs moving because they hurt so bad they're trying to get away from the pain? Or are they crying and you cannot console them? It's a great tool. We use that for the newborns, the young kids up to age 3. And then we use it for nonverbal children. I've used it on nonverbal 18-year-old cerebral palsy children, and it works great, okay? It's a great tool. Now, the other thing that we use is at preschool, so ages 3 to 5, we're going to use the FACES scale. And the FACES is this one right here. And these kids, and I had on my badge, I had the FACES there. I'm like, so tell me, how much do you hurt? This one here means you don't have any pain at all. And this up here is like really horrible, horrible pain. how do you hurt? And they will point exactly where they hurt. And kids, as I said, it's amazing. They will tell you exactly what their pain is. I mean, pain can be due to mostly anything. Could be due to they've had surgery, could have, a cast put on, could be ear aches. Oh my God, ear infections, they hurt and they cause a lot of pains. It could be braces, all different sort of stuff. It could be chronic, reoccurrent, persistent. I mean, what about the child who has sickle cell disease? There's going to have times where they do have sickle cell crisis and they hurt and tell me they hurt. So they will be getting good doses of medicine. And kids, for instance, the rheumatoid arthritis. Can you imagine being in pain all the time? And they still haven't taken that rheumatoid arthritis and made it to a point where the pain isn't bad. It takes an emotional stress on you because as a kid, you want to get up and go like every other kid, right? And if you can't, it does wear on you. And it's that emotional, social, and even what you're doing in school, you're not going to do well. As I said, with non-communicating, there are different scales. Whatever your hospital has, that's what you use. I'm just introducing you into some of them. Now, how do you do pain? Well, number one, you have to go in there and find out, do an assessment. Do they have pain? And then you have to do an intervention, some sort of medicine. Do they need morphine? And morphine can be used extremely safe. Or do they just need Tylenol or ibuprofen? Either one of those can be used. Or do I need to put it in between a dose? But remember, there's other stuff that can be used for pain. Distraction. Now, kids, give them a video game, give them a TV show, give them some crayons and a coloring, give them stickers, give them a toy. These kids forget they have pain. It takes their mind off of the hurt. It works. So absolutely it should be used. Also, positioning. Maybe they need the head of the bed up. They had an appendectomy and they're laying flat. Their stomachs are stretched, right? Put the head of their bed up. Give them a pillow for their tummy. All of these little repositioning things. If it's RA, how about a cold pack, a hot pack? Same thing for sickle cell. Give them a hot pack. These are things we can use. It's not just the medicine. And in infants, we're going to swaddle them. They like that comfort of being like this. That's what they want to be. And the one thing about non-nutritive sucking or a pacifier, it was shown by Harvard neuropsychologists or physiologists that a pacifier with a little bit of sugar water on, they can do a circumcision with just them sucking on a pacifier. It equaled the same amount of pain control that morphine did. So that's why they're just doing that little sugar water. It works. My grandson had it done that way. And he cried because he was held down. Kids don't like to be held down. Even 1-month-old kids, they don't like it. As soon as he was let up, he was fine. Sucked on a pacifier, he was good. And then here's kangaroo care. This is a great thing. You have a newborn nurseries, have a premature baby born, mom wants to hold her baby. The baby wants to be held in that warmth. These kids in the warmers and the isolates, they're moving and they're uncomfortable. Pick them up, put them on mommy's bare chest, cover them up, have mommy sit there. They fall asleep, their heart rates come down, their blood pressure comes down, and they're just so happy. So do they have pain? Not on mommy. So all of these things can be used for it. As I said, it's not just the big guns, morphine on these children. It could be just acetaminophen. It could be your NSAIDs. It could be a lot of stuff. On the older kids, we do use PCA pumps on some of those children with some big surgeries. And again, as I said, hot pack, cold pack, and moving and positioning those kids. I mean, this kid right here, this little girl's just about to get her blood drawn and she's smiling. And why is that reason? She's got that little white little glob is EMLA. It is a numbing cream with a little Tegaderm on top. Let it sit there for 20 minutes. Take it off, wipe it off, put a needle in, she doesn't feel a thing. Does not feel a thing because it was numbing cream. And that's what we're doing in the pediatric world. They don't do it for adults yet. They don't care about us. Boom, stick in that 18-gauge needle. And yeah, but with children, we're being very careful so that they do get the treatment they need without all of that psychological trauma that we used to give them. Pain sites, I've already talked about a lot of them, the teething. How about just immunizations? You know, think about that 2, 4, 6 months. We give like these bunches of immunizations. And that leg, you know, that vastus lataris muscle where we give it, is all red and hard and inflamed and it hurts. Well, we can give acetaminophen up till 6 months old. And at 6 months, we can introduce ibuprofen. We do not give ibuprofen before 6 months old, only acetaminophen. But we can put a hot pack on there. And then something called bicycling, where we take the knees up and we move it. And that can help with the movement of that stuff around. When I got, just 2 weeks ago, I got my booster for the COVID. I had my arm and I was moving it and moving it and moving it. You know, it never got swollen, never got red, never got hot and didn't hurt because I was using my, you know, bicycling on my arm. So it didn't happen. So I'm telling you firsthand, it does work. You know, burn pain's the hardest one of all because it could be first, second, third degree, and the first degree hurts the worst. So headaches because of braces. You'll see a lot of kids with recurrent abdominal pain, and that could be stress. It's something that needs to be ruled out. As I said, sickle cell, and then cancer. And we do have children that do have end-of-life care. And as much as I would say it's hard, I want you to know that hardest part of nursing in pediatrics is that a child will die. There's nothing you can do. But just remember, it's not that they died, it's what did you do for that child and that family when they were alive? You know, I have many parents who reach out to me like on Nurses Week from 15, 20 years ago saying, this is to Chris's favorite nurse. Happy Mother's Day, happy Nurses Week. You'll always be in our hearts. The kid died. You know, it's like I gave my heart and soul to that kid. Those kids are mine. I call them my kids in the hospital. And it's very rewarding and it hurts and it's okay. But again, what did you do for that child and that family when they were alive, right? Okay. Which of the following is an important factor for consideration in understanding the pain experience in children?
B.
They're not going to admit it. You're absolutely right. Because they don't want the pinch. Or you have the father saying, oh, you don't hurt, don't worry, you don't need nothing, right? Well, I think we have time to start our cahoots. I want to get it going. It's, I believe, 30. I think we'll be right there where we need to be. I'll just try not to be long-winded, okay? Any questions so far, everybody? So you go on your phones, you go to kahoot.it, and you pull it up. On the computer, you're going to see the answers, and you push on the phone what answer you want to do, okay? So you need a phone and your computer. All right, I'm going to get going so we get out of here on time. Here we go, week 1. From a worldwide perspective, infant mortality in the United States. What did I tell you about the death of young children in the United States as compared to the world? And this is statistics by the World Health Association organization, WHO. Ooh. We know that we have more deaths in the United States than many other countries in the world. And we are catching up, but we're still not there yet. And it has to do with prenatal care and postnatal care, all that. The leading cause of death from unintentional injuries in children is, again, unintentional means you didn't try to hurt this kid. It just happened. And I want you to know it's any age child, from infants to adults. And it is motor vehicle fatalities. It's having the wrong seat in, facing the wrong way, all of those things. Car seats are very important.
Okay.
Which statement is most descriptive of pediatric family-centered care? Remember, family is the constant in that child's life. So whatever the family doesn't know, that's what the child knows. They don't know any more than that, especially your younger kids. The major cause of death for children older than 1 year old is what? I mean, when we get to be adolescents, we know it's suicide and fatalities like gun violence. But in young children, it's unintentional injuries. I call toddlers my dive bomb kids. They have absolutely no filter or no fear. They jump off couches, trying to hit the other couch, fall on the floor, and bop their head. This is just what they do. They're exploring. The nurse caring for the child in pain understands that distraction. Remember, distraction is a great thing to use with children because it takes their mind off of it. But you have to make sure that the distraction you use is appropriate for the age child. You're not going to give an infant a sticker. It's not going to work. But maybe putting on a little music and show them a little rattle will work, okay? So make sure it's age appropriate. And what type of play are children engaged in similar or identical activity without organization or a mutual goal?
I think it's this one. Carol.
So next to each other is associative, all right? But they're playing similar. That means they're doing the same things. Parallel, they're doing opposite things, but next to each other. And cooperative means they're playing the similar thing together, but there's a goal in the end, okay? Those 3 ones you need to know. You will see them.
Okay.
Which statement best describes the process of critical thinking?
Oh, I know that.
I describe critical thinking as I need to make dinner. I know what I have in the house. I go to the grocery store, get the rest of it, go home, and I make it. It's just understanding it's purposeful and it's goal directed. You know what you need, and then you go for it, whatever that goal is. What is probably the single most important influence on growth at all stages of development? I've said it, I think, 3 times already today. Nutrition, 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 right? You got to feed the brain in order for it to grow properly. Frequent developmental assessments are important for which reason? So we know that there's certain things that children do. You know, they're gonna first lift their head up and turn over and creep and crawl. We know that this is gonna happen. If they're not lifting their head up by 4 months old, or when you pick them up, their head lags, there's a problem. So if we see that during that developmental assessment, we can start early intervention and get that kid caught up. That's the goal. Which function of play is a major component of play at all ages? What does play do? Like that rattle. It's sensory motor activity. I mean, I know Freud talks sensory motor, but play is the touching of it. They want the texture. It is everything explored in the mouth. The 5-year-olds always have the pencils in their mouth, crayons in their mouth, everything in their mouth. I mean, I'm still to this day, my grandson is 6. Get it out of your mouth. It's dirty, but they keep going. But sensory oral motor, and then moving it around and playing with it, you know, taking it and flying in the air, whatever they do. Sensor or motor, all components of play. 3 children are playing a board game would be considered of what type of play? It's a board game. It's checkers. And that's cooperative play. Excellent, good job. There is a goal in the end. Board games have a goal, a winner. The head to tail direction of growth is referred to as, which means we start lifting the head up first, and then we roll around, we creep, we crawl, and then we take steps. That is all called this. And when you think of head, think of cephalic, right? Cephalocaudal. Proximal distal is how they start here with everything close, and then they start reaching out from the hand. So it starts proximal, and then they start working around, touching things on the outside. That's part of the proximal distal. What is the single most important factor to consider when communicating with children? I want to get this kid to get a height on him. What do I need to do to get him there? And their developmental level. Get on their level, let them understand you, and then let them play with whatever they need. And I'm telling you, the kids will help you. Then they'll think it's a lot of fun. That nurse was fun. I liked her. What 2-year-old child pain assessment tool should the nurse use? And we talked about FLAC, faces, and numeric. Those 3. Which one is for that 2-year-old? And the 2-year-old is FLAC. It does not become faces till preschooler. At age 3 is when it becomes the faces, okay? It's a common error, and it's a good question to remember that answer. At 6 months, an infant's birth weight should do what? Now, this is just part of the physical assessment. You're going to hear this again next week. but I think it's a great question for you to start with. And at 6 months, they double. And at 1 year, they triple. And at 2 years, they quadruple, 2.5 years. The first expected fine motor developmental milestone for an infant begins with. Now, in infants, we have gross motor, which is movement, get up and go, 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 lifting the head, crawling. Fine motor is F, fingers. And we start out with them grasping, right? So the first one that they do is all the reflex. And then it becomes voluntary. So reflex palmar, voluntary palmar, crude pincer, then it's neat pincer, then putting things into a container and blocks of 2 by 1 year. That's fine motor, fingers, what we use, F, fine fingers. At 8 months old, an infant should be expected to perform which fine motor skill? Remember again, F is fine, which is fingers. I mean, the last thing that we do is put it in the container and do blocks of 2. So right before that 8 months is that getting that rattle and also crude pincer. It means just a smush of getting the Cheerios off of the high chair end. And then eventually they go one at a time. And that's called fine. The natural physical sequence that most children follow is what? What do they do first? I've mentioned it a couple of times already today. They lift their head, roll over, creak, crawl, cruise, and then they maybe take a couple of unassisted steps by 12 months. Now, if they're not walking at 12 months, but they are attempting, is that child behind? No. Just remember, all kids aren't the same. I have had 2 children and my grandson, they never walked at 12 months. At 15 months, they ran. They never walked. They ran at 15 months. Which behavior indicates that an infant has developed object permanence? And again, even though it's hidden, not in sight, they still know it's there and they go looking. In general, an infant should triple their birth weight at what months of age? Well, we've already said we double at 6 months. So when do we triple? And that's at 1 year. Very good. Perform a head-to-toe assessment on a toddler. Most important to consider before beginning the examination. Remember, toddlers are ages 1 to 3. So again, get on their developmental level. Make sure that they're understanding you, they've gained confidence with you, and then they'll let you do things for them. And the one thing I want to, anybody who has children, remember the book. Don't think about what your kids do. Sometimes that will confuse you. According to Piaget, toddlers are in the blank developmental stage. And we're going to talk about this more, but remember I told you all of the stages they're in this. And it's the sensorimotor. All the children start there, whether it's Freud, whether it's Piaget, they're all everything about in the mouth and moving it and all about the texture. Which intervention helps a hospitalized toddler feel a sense of control? You know, toddlers are the hardest ones because they don't like change. They like to be in their own, environment. So how can we help them feel a little safer? And it's the routine. The routine is the most important thing. To get the bath the same time, and if we can feed them the same types of food, it will make them feel better. We can't always require parents to stay. Parents have to work. Parents have other children too, but we can keep them on a routine, and that does help. All children reach developmental milestones at the same age. Yes or no? Absolutely not. They're all different, and that's why I love kids. And all your assessments are different on all kids. On adults, you'll see a gallbladder is going to have all this same thing happen. On a child, it's always different, and that's what I loved. It kept me on my toes. Immunizations for a 4-month-old infant. What action should the nurse take to provide a traumatic care for this infant? How did I tell you we can decrease pain in an infant? And that's good old pacifier with its sugar solution. We used to call it Sweeties, was the name of the product. And we would always carry it in our pockets, put it on, and let me tell you, it does work. And it's self-soothing again, it helps. Which of the following immunizations could be administered to a newborn? What's the first one we give? Again, we'll be discussing this more next week. And that's your Hep B, usually given at the hospital before they go home, or at least in that first visit immediately after, they'll be given Hep B. The normal heart rate for an infant is 140 to 160. So if my heart rate on an infant is 180 and they're asleep, there's a problem. Are they dehydrated? Do they have a fever? These are things I'm going to be looking for. What is the preferred site to give an injection to an infant? And that's the vastus lateralis. We give them there. Very good. And you never give an injection like what you just saw there, because that infant could move. And I've seen those needles really scratch and injure children. So I don't ever give it alone. The death of an infant under 1 year old with no known cause is what? And it's one of the reasons why we put our children on their backs to go to sleep today. We'll talk about that more next week. Very good. A Vietnamese mother of a child avoids eye contact with a nurse, considering cultural differences. Why? And again, this is respect for the nurse. I mean, if you didn't know, you wouldn't understand. And the one thing I can tell you, if you don't understand a cultural something with a parent, I will tell you that most of them appreciate you asking. So why don't you look at me? Are you afraid? What's the matter? And they will tell you that in their cultural, they don't. And they will appreciate you saying that. They really will. A child from Mexico is hospitalized for a serious illness. The father says the child's being punished by God. Why is he saying that? And again, it's a health belief, you know, and if we know that, we could say, listen, there's nothing you did wrong. It's just sometimes the appendix needs to come out. You know, it could be as simple as that. What terms refers to a times when individual's life where he or she is more susceptible to positive or negative influences? Again, this is one of those terms that was on that slide. And when you talk about the word susceptible, you think of sensitive. It's the sensitive period when they're more able to pick up good things and bad things. You know, the children will listen more and be apt to change. What is a characteristic of the pre-operational stage of cognitive development? Now, again, this is ages 2 to 7. I'm going to go over this more. Next week, it has to do with Piaget. But looking at a 2 to 7-year-old, what would you think? So they have to see it to understand it. They can't just try to figure it out. As in, they took the rattle and they shaked it and they knew it made a noise. That is, they understood it because they saw it. It's concrete, it's visible. And last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? Remember, Kohlberg's all about good and bad. And children start to know what they can do and what they can't. And they start to know that there's going to be time out, right? They do something wrong. Preschoolers, ages 3 to almost 6. And again, it's good or bad in terms, and then a consequence for either good or bad. Good job, guys. Number 3 is Chad. Good job, Chad. Whoop, whoop. Number 2, JP. Number 1, Jessica. Number 4, Ashley and Shayla. Good job, guys. Okay, that's the end of today's class. I did good. I got you out in time, and I was able to get the Kahoots in, which I wasn't the first class. So I'm glad I could do that. I will be posting all that stuff and the Kahoots for you so that you will have it. Again, anything you need. I will be sending you also the dosage calc information with the 3 worksheets that go with it. If you need more than that, please just send me a message and I will definitely work with you to try to help you. And all I need is 20 minutes, half an hour. I don't need 2 hours of your time. I know how precious it is, and I won't hold you, okay? Any questions? Have a good day, guys. Nice meeting you. Take care.
Is next week, beginning of class?
Beginning of class. Yes, there's a quiz on this week's information.
Okay, thank you.
You're welcome.